His deep tendon reflex is more. Okay. Uh, NSAID can be given. I don't think. Okay. Is it reassurance? Okay. Okay. Low back pain during pregnancy. Etiology is enlarged uterus, exaggerated lordosis, joint or ligamentum laxity, from increased progesterone or relaxin, weak abdominal muscle, decreased lumbar support. Risk factor: excessive weight gain, chronic back pain in prior pregnancy, and multiplicity. And imaging is not indicated. And management is behavioral modification, heating pad, and analgesic. Behavioral modification, heating pad, and analgesic. Okay, low back pain. Low back pain are common in pregnancy, especially in the third trimester, because uterine enlargement causes exaggerated lordosis and postural changes. Other contributing factors include weakened abdominal muscle and increased joint or ligamentum laxity. Risk factors include multiplicity and excessive weight gain in this patient. Prior neuroaxial anesthesia does not increase the risk for long-term back pain. Back pain during pregnancy typically manifests as mechanical back pain, position-dependent, achy, worsened with activity relieved with rest. In contrast, concerning non-mechanical causes of low back pain and preterm labor pyelonephritis spinal malignancy may present with fever and neurological deficit, bowel and bladder incontinence, and constant non-positional nocturnal back pain. The patient has no neurologic deficit. He has back pain without radiation below the knee, making lumbosacral radiculopathy sciatica unlikely. The numbness is in her feet, which is present only at the end of the day and is likely related to physiologic ankle edema. Patients with no concerning findings such as these one should receive reassurance that the back pain is normal and will resolve postpartum. Conservative management such as behavioral modification, wearing supportive shoe, using firm mattress, exercise is recommended, and heating pad and massage are also beneficial. Okay. Do, okay. He has 8 weeks of gestation, and she has elective abortion. Uh, but now fever. Is it infection? So is it sepsis like septic abortion? So say S for sepsis, S for suction curage. Okay, okay. Septic abortion. My brain is working like DeepSeek AI. In DeepSeek AI, what is the problem? Do you know? In that AI, it take time. It actually takes time to give answer. It actually takes the question, then it starts thinking, and within 90 minutes it gave answer. But others AI gives early answer. Okay, that's why I. Okay, 1 minute. My mom is calling. 1 minute. Hello, 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 hello. Okay, now this patient's presentation is consistent with septic abortion, which typically presents with fever, lower abdominal pain, and heavy vaginal bleeding and malodorous purulent vaginal discharge. It can occur as a complication of any type of abortion, but most frequently follows an unsterile and or incomplete procedure for an elective abortion. Findings of purulent discharge, and an enlarged boggy tender uterus on pelvic examination, as well as ultrasound showing intrauterine echogenic material with blood flow are consistent with inflammation and infection from retained product of conception. Although the infection usually remains confined to the retained product of the conception, if untreated or observed, it can spread to the uterine myometrium and can cause widespread infection. Because of these potential complications, a septic abortion is a medical emergency that requires prompt treatment to prevent progression to peritonitis septic shock, and death. Treatment include broad-spectrum antibiotic, uterine evacuation, and with suction curettage, which removes the needles of the infection. Okay. Okay. This is maternal beneficence. Okay. Beneficence is the physician's obligation. Beneficence is the physician's obligation to act in the best medical interest. Act in the best medical interest. The primary patient during pregnancy is the mother. Therefore, when the maternal and the fetus interest conflict, which commonly occurs in the pregnancy, maternal decision making often based on prioritizing maternal health, maternal beneficence over fetal interest. The patient has triplet pregnancy, multiple gestational pregnancy, twin triplet, have maternal morbidity including increased risk for preeclampsia, cesarean delivery, and PPH, fetal complication, growth restriction, term delivery, and term delivery are also more common. After considering these risks, patients may choose patient may choose to continue multi-fetal pregnancy and undergo pregnancy reduction, a procedure that includes asystole in one or more than one fetus to create a lesser order gestation, singleton pregnancy. Multi-fetal pregnancy reduction chooses the reduced fetus randomly. In contrast, selective termination selects intentionally by fetal trait, sex, or chromosomal abnormality. In this scenario, the decision to perform a multifetal pregnancy reduction multifetal pregnancy reduction is primarily based on maternal beneficence because reduction to a singleton pregnancy would decrease these patients' risk for preeclampsia, PPH, and cesarean delivery. Any fetal benefits gained, such as improved odds for term delivery of the remaining fetus, are secondary to the primary principle of maternal beneficence. I don't know what they are talking about. I'm just reading. For for yes, I have got that point. Like what I have understood, like if she has multiple pregnancy, like triplet pregnancy, it has multiple complications. Like mother has the risk of dying also. Like PPH can cause dying also. So preeclampsia can happen. She has a history of preeclampsia also. So she has multiple problems. So there is risk of dying. So that's why the mom is taken in the mom has taken a decision in the interest of her own benefit as well as to get a healthy baby. Like getting three and all of them are like sick and getting one is better. That's what she thought. Yes. Okay, I am reading. If you got the point, you make me understand. Okay. Beneficence forms the foundation for many other ethical principles like non-maleficence justice. Non-maleficence differs from beneficence in that beneficence require the addition of benefits, a positive requirement rather than avoidance of harm through a non-action, a negative requirement. In this scenario, upholding fetal or maternal non-maleficence would involve expected management, not performing the procedure because the procedure itself carries risk. Yes. Okay. Yes. Yes. It's not infection. It is not placenta previa also. Yes. Painless bleeding has two DDs, placenta previa and vasa previa. A placenta previa can cause painless bleeding, but placenta previa cannot comes with rupture membrane and it cannot comes with absent fetal heart tones. Usually It does not cause that rupture membrane. Okay. And placenta previa has another thing in the ultrasound, like placenta covering the internal os. Okay. Nothing is present in here. Like fetal abnormality, like fetal heart rate abnormality is must for vasa previa, not for placenta previa. Okay. So, okay, normal fetal vessels travel the umbilical cord surrounding by thick gelatinous tissue, Wharton jelly that protects the vessel. In contrast, vasa previa is an aberrant condition in which fetal vessels overlie the cervix, surrounded by a thin fetal membrane. Their location over the cervix and lack of protection by Wharton jelly makes this vessel prone to tear with rupture of the membrane and or contraction. Vasa previa is typically diagnosed on fetal anatomy ultrasound at 18 to 20 weeks of gestation, and patients normally require third trimester inpatient management with cesarean delivery at 34 to 35 weeks of gestation prior to the onset of the contraction or membrane rupture. However, vasa previa may be clinically diagnosed when patients such as this one present with rupture of the membrane accompanied by painless minimal vaginal bleeding, and the primarily reflects fetal blood loss from a torn fetal vessel. Vaginal bleeding is minimal because total fetal blood is low, 250 ml or 1 cup. However, fetal bleeding hypotension from fetal bleeding can lead to fetal heart rate abnormality, bradycardia or sinusoidal pattern, and rapid fetal exsanguination or demise. Okay. Okay. Can you give me 10-minute break? My sister is calling me. Lots of people are calling now. I don't know why. Okay. Yes, we are on new question. Risk of risk of what's her problem? Like sorry. Okay. yes, fetal is maturity. Like one twin may become big and one twin becomes small, uh, or or it is fetal macrosomia. One with okay. It is the patient is at increased risk of which of the following obstetric related complication? Yes. Preterm labor for mother like obstetric complication maybe, and preterm labor for twin. Okay. If it is for fetus, what would be the complication? Fetal dysmaturity. Okay. Okay. Fetal dysmaturity syndrome occurs in post-term more than 42 weeks of gestation. More than 42 weeks of gestation pregnancies due to age-related placental change. Age-related placental changes. Age-related placental changes and resultant uteroplacental insufficiency units are small for gestational age and have a thin body with loose skin and have meconium stained amniotic fluid. This maturity syndrome does not occur in twins because they are delivered preterm or term. This maturity syndrome does not occur in twins. Okay. Okay. This maturity does not happen in twins. Okay. And it happens in the post-term pregnancy. Um, so these she is only 12 weeks of gestation, so we do not know it will be post-term or not. Okay. The most common complication of the twin pregnancy is preterm delivery, less than 37 weeks of gestation, which occurs due to either spontaneous preterm labor, or indicated delivery for management of maternal and fetal complication. The increased risk for spontaneous preterm labor and delivery in twin gestation is likely the result of multiple gestation, and uterine overdistension, uterine size state discrepancies. Uterine overdistension causes overstretching of the myometrium, which results in increased prostaglandin production and number of oxytocin receptor and contractility within the uterus. An induced preterm delivery occurs more often in twin gestation due to an increased maternal preeclampsia and fetal growth restriction, discordant growth complication which require preterm delivery for disease management. Due to spontaneous preterm labor and a medically indicated deliveries, more than half of all twin pregnancy delivers uh, more than half of all twin pregnancy deliveries occur before 37 weeks of gestation. Okay. Yes. Twin pregnancy. Monochorionic, monoamniotic, one placenta, one amniotic sac. Monochorionic, diamniotic, one placenta, two amniotic sac. A monochorionic MD, monochorionic diamniotic is T sign, T sign at inter twin membrane, and dichorionic diamniotic has lambda sign. Two placenta, two amniotic sac, lambda sign at intertwin membrane. Maternal complication is hyperemesis gravidarum, preeclampsia, gestational diabetes mellitus, and IDA. And fetal complication is congenital anomalies, fetal growth restriction, preterm delivery, malpresentation, breech, monochorionic twins, twin transfusion syndrome, and monochorionic twins, conjoined twins, and cord entanglement. Okay. Patient is hemodynamically unstable and transvaginal reveals a gestational sac in the upper left corner. So just is it ectopic? Yes, surgical exploration. Okay. This patient with an acute abdomen, severe pain, guarding likely has hemoperitoneum from a ruptured ectopic pregnancy. Although most ectopic pregnancies implant in the ampulla of the fallopian tube, implantation occasionally occurs in the upper outer corners of the uterus cornu, where the uterine wall meets the proximal interstitial fallopian tube. These are known as cornual or interstitial ectopic pregnancy. Specific risk factors for cornual ectopic pregnancy include uterine anomalies, bicornuate or unicornuate uterus, and in vitro fertilization. The cornual region receives an abundant blood supply from the uterine, abundant blood supply from both the uterine and ovarian vessels. Therefore, rupture in these areas often leads to life-threatening intra-abdominal hemorrhage as well as heavy vaginal bleeding because blood is highly irritating to the peritoneum. Patients with hemoperitoneum develop peritoneal inflammation and severe diffuse abdominal pain. The accumulation of blood can be seen on ultrasound as free fluid in the posterior cul-de-sac. Patients with hemoperitoneum and hemodynamic instability, hypotension, tachycardia require emergency surgical exploration to remove the ectopic pregnancy and achieve hemostasis. Yes, dilatation and curettage removes the uterine contents and for a can be performed for a spontaneous abortion, inevitable septic which may present with abdominal pain and vaginal bleeding. However, specific spontaneous abortion do not cause hemoperitoneum pelvic free fluid. Methotrexate is a treatment option in patients with an early unruptured ectopic pregnancy. Ruptured ectopic pregnancy is a contraindication to its use. Okay. Misoprostol can cause cervical dilatation and myometrial contraction to expel the intrauterine contents. Therefore, it can be used to treat spontaneous abortion. It is not effective as ectopic pregnancy and is not used who are hemodynamically unstable. TSH is low, very low. Fetal heartbeat is unable to identified by the Doppler. Beta ECG is elevated. Maybe there is somewhere. And she has a history of raw and Y gastric bypass. Uh, and pressure is high. So looks like ectopic. Now think about other areas. In inevitable dilate cervix is dilated. Product of conception is can be seen and there is vaginal bleeding. As far I remember, it is not inevitable abortion from thyroid arises from the thyroid gland. Yes, may it is not stroma ovary. Stro, strom, yes, but it's like it generates from the thyroid gland, but the mass is in the ovary, like that. Okay, this patient, I was wrong very before. That's why I told you to think otherwise. I keep practicing very early. Okay, so this patient's presentation of heavy vaginal bleeding due to passage of hydrophic villi over hyperthyroidism, elevated beta ECG, and enlarged uterus is concerning for heredity for mole. Risk factor from identiform mold include a vitamin A deficiency, Rho and Y, surgery, and extremes of maternal age. Patients aged more than 40 with identiform mole are at risk of severe complications. Identiform mole is a non-viable abnormal gestation comprising the hypertrophic and hydrophic placental trophoblastic villi. The trophoblastic atrophy leads to marked elevated HCG level, but because HCG, both alpha and beta subunit, and TSH have a similar structure, elevation in HCG can mimic TSH and can cause an increase of triiodothyronine T3 and T4 concentration. However, the markedly elevated beta HCG levels associated with high form mole can therefore cause overt hyperthyroidism, hot flashes, tachycardia, smooth, warm skin, low TSH. As seen in this patient, this complication can resolve after treatment as the HCG level decreases and the T3 and T4 level normalizes. Yes, an ectopic pregnancy typically presents with unilateral pelvic pain and vaginal bleeding. Because it is extrauterine in location, an ectopic pregnancy is not associated with increased enlarged uterus. In addition, there is no association with hyperthyroidism. And endometrial cancer can present with abnormal vaginal bleeding and mild uterine enlargement, but there is no association between endometrial cancer and elevated beta HCG and hyperthyroid state. An inevitable abortion presents with vaginal bleeding and a dilated cervix. This patient's cervix is closed and the inevitable abortion does typically occur in first trimester, which would not the cause of uterine fundal height equivalent to 16 weeks of gestation 4 centimeter below the umbilicus. Okay. Periangual fibroma. Um, heterozygous disorder. It is assume the patient is heterozygous. Okay, we need to find out the diagnosis first. Okay, periangual fibroma, optic lima fibroma, hematomas, hemat- uh, okay, I think it's Starch-Weber syndrome. Looks like Starch-Weber. In Starch-Weber, there is stain, tram track calcification, unilateral GNAC gene, and there is epilepsy. Mm, Tarsh, unilateral gene X gene. Then 50% chance, like in if you think about autosomal dominant, there is no boy or girl variation. No, yes. So, but am I diagnosed? No, it's not tuberous sclerosis. It's not Starch Weber. Sorry. Yes. Okay. Okay. Hey, this woman with epilepsy. This woman has epilepsy and skin finding concerning for tuberous sclerosis. Tuberous sclerosis is autosomal dominant. I missed it. Okay. Tuberous sclerosis. Oh, sorry. This patient has epilepsy and skin finding concerning for tuberous sclerosis complex, a neurocutaneous disorder. Classic dermatological finding: ash leaf spot, hypopigmented macule, periangual fibroma, flesh colored papille adjacent to the nail fold, flesh colored papule adjacent to the nail fold. There is malar angiofibroma. There is Sjagren's patches, orange peel-like plaque typically on the lower back. Most patients have seizures and benign tumors in the multiple organs, skin, brain, and kidney. The diagnosis is often clinical, can be confirmed by genetic testing. TSC is a mutation in the TSC1 or TSC2 gene. The mutation can occur de novo or may be inherited through autosomal dominant transmission. With autosomal dominant disorder, a child a child needs to inherit it. A autosomal with autosomal dominant disorder, a child needs to inherit only one copy of the mutant allele to be affected, and males and females are affected equally. In this case, one parent of heterozygous for the condition, one mutant allele, and the other is healthy. Therefore, the child of the couple has 50% chance of inheriting the disorder, regardless of whether the child is a boy or a girl. However, clinical features vary within family members, so the severity of the disease cannot be predicted. Okay, or look at the option B. The likelihood that the two carriers of autosomal recessive disorder will have a boy who is affected, 12.5%. Likelihood of having a boy and likelihood of disease, zero point 0.5 into 0.2.5. Okay. is she has like placenta previa, like placenta, posterior placenta extends over the cervix, like placenta covering the cervix. There is no bleeding, painless bleeding, but this placenta previa or abruptio placenta happens after 20 weeks. So it is 20 weeks of gestation. So maybe it's placenta previa, and she has done cesarean section. So one of the risk factor of this, maybe. What's your thought? Okay, look at the ultrasonogram and trying to memorize. This is placenta, this is cervical canal, this is internal cervical box, this is external cervical. I know I can't remember, but still I go through the picture. Sometimes it works. Like if this picture gets common, your brain may struck. Okay. So this patient has placenta previa in which the placenta extends over the cervix. Extends over the cervix. Most patients are asymptomatic and are incidentally diagnosed on second trimester ultrasound, as in these patients. Patients with placenta previa require pelvic rest, no intrauterine or digital cervical examination because because minimal cervical manipulation can cause cervical changes, shortening, dilatation, and can result in partial placental detachment and massive maternal hemorrhage. Placenta previa can occur in pregnancy. However, this patient's major risk factor is her prior cesarean section. Increasing cesarean delivery rates have caused an increased incidence of placenta previa because the uterine scar and the change in the vascularity because the uterine scar and the change in the vascularity likely alter early pregnancy likely alter early pregnancy implantation. Additional risk factors include prior placenta previa, multiple gestation, increased placental surface area, and advanced maternal age more than 35. Most cases resolve spontaneously by the third trimester due to physiologic lower uterine lengthening and placental growth towards the fundus. Patients with placenta previa should undergo a cesarean delivery at 36 to 37 weeks of gestation prior to the onset of the labor. Okay. Okay, this woman has positive IGRA, which means that she has an infect. That means that she has been infected with tuberculosis. Tuberculin tests and interferon gamma release assay are safe, reliable methods for screening for TB during pregnancy. Screening is recommended in those who report close contact to a person with known TB travel from high risk country, likely this patient, and are exposed to a high risk setting, homeless shelter. The next step after a positive screening test is to differentiate active disease from latent infection. Latent TB is defined as a reactive tuberculin stress test or IGRA with a negative chest X-ray and absence of symptom. These patients' optimal next step is these patients. mm, Okay. Therefore, the optimal next step in management is to obtain a screening for X-ray. Chest X-ray during pregnancy is safe and is appropriate shielding and should be pursued if it immediately affects management, as in these patients. If the chest X-ray is abnormal TB disease is likely, and the sputum culture should be obtained. If the X-ray is normal, latent TB is confirmed. Okay. Yes. Tuberculin, tuberculin, tuberculin test is an option for the initial diagnosis of the TB infection, but can falsely positive in patient who has received BCG vaccine. In contrast, IGRA is not positive after BCG administration, BCG immunization. There is no benefit in retesting the patient with a different assay when the secondary, sorry, when she already has positive IGRA and this patient has not been diagnosed with active versus latent TB, so it would be inappropriate to begin multi-drug therapy for active disease given her given her absence of symptoms. Latent TB is more likely because a chest X-ray is indicated to confirm the diagnosis. Yes, I'm I'm thinking that's is it rupture? So this patient with restless intense sudden onset lower abdominal pain, this patient with intense restless this patient with intense restless this patient with restless and intense sudden onset lower abdominal pain most likely has uterine rupture, a disruption of the uterine wall typically associated with contraction. Uterine rupture usually occurs in patients with prior uterine surgery, cesarean delivery, myomectomy, because weakened uterine scar can separate with the force of contraction. Patients can develop massive bleeding intra-abdominal, vaginal due to highly vascular pregnant uterus. When the uterus ruptures, the sudden decrease in intrauterine pressure and into the maternal partial fetal delivery into the maternal abdomen can result in the loss of the fetal station. Fetal parts may also become palpable abdominally and irregular protuberance. Patients typically develop an abnormal fetal heart rate tracing, including recurrent variable and late deceleration caused by umbilical cord compression and reduced uteroplacental blood flow, respectively. To further to prevent further maternal and fetal compromise, management includes emergency laparotomy and cesarean delivery. Okay. TSH low, T3 hyperthyroid, low uptake of radioiodine. So grapes. Low uh, postpartum. Is it postpartum thyroiditis? Okay. Okay. Radioiodine uptake findings in thyrotoxicosis. Normal or increases GTT, Graves' disease, toxic multinodular goiter, and toxic nodule. And decreased is painless thyroiditis, subacute thyroiditis, subacute thyroiditis, amiodarone induced thyroiditis, Sareptors or excessive levothyroxine use, stroma ovary, iodine induced metastatic thyroid cancer. This patient this patient clinical features fatigue, weight loss, tremor. Lab findings include lab findings mm, lab findings decreased TSH, elevated T4 and T3 consistent with hyperthyroidism, thyrotoxicosis. The most common cause of hyperthyroidism The most common cause of hyperthyroidism are Graves' disease and painless autoimmune thyroiditis, which both can cause painless symmetrically enlarged thyroid. Patients with another autoimmune patients with another autoimmune disease, type 1 diabetes mellitus, are increased risk of both disorder. This disorder can be differentiated by radioiodine skin, which shows the metabolic activity in the thyroid. In Graves' disease, the thyroid is stimulated by autoantibodies. Thyroid is stimulated by autoantibodies. Mm, okay. In Graves' disease, thyroid is stimulated by autoantibody to increase tissue metabolic activity, causing increased thyroid hormone synthesis, as evidenced by uptake of radioactive iodine and increase release of thyroid hormone. In contrast, the in painless autoimmune thyroiditis, the thyroid tissue is destroyed, leading to increased release of preformed thyroid hormone and resulting hyperthyroidism. The decreased thyroid cells are unable to synthesize thyroid hormone, as evidenced by low radioiodine uptake. A form of painless autoimmune thyroiditis, which can occur within 12 months of the delivery. Patients with postpartum thyroiditis can have a variable disease course based on the amount of thyroid destruction and recovery, including being hyperthyroid only, as in this patient, hypothyroid only, and hyperthyroid then hypothyroid. The diagnosis can be confirmed with a positive thyroid peroxidase antibody. Most patients eventually return to a euthyroid state and do not require treatment. Magdala interaction. Yes, magnesium sulfate is given. She has what can I say? She has eclampsia, not eclampsia. She has preeclampsia, PE. So she has 6 hours later. So it may be due to magnesium toxicity, like as very high magnesium is given in preeclampsia to control seizure. To prevent seizure, we give magnesium sulfate, and nifedipine is given for lowering the blood pressure. And and we are trying to remove the criminal. The placenta is the main culprit here. So if we deliver the patient, then his preeclampsia or eclampsia may be cured. So I'm talking here and there. Most likely, why there is hypermagnesemia. That's the main thing. Yes, yes, yes. Magnesium actually excreted through the kidneys. Okay, you are right. Okay, magnesium sulfate is the treatment of choice for prevention of eclamptic seizures. It is also administered to patients for whom preterm delivery is imminent because it decreases the risk of CP. It decreases the risk of CP, cerebral palsy, in premature infant, fetal neuroprotection less than 32 weeks of gestation. Common adverse effects include headache. Uh, Common adverse effects include headache, nausea, fatigue, diaphoresis. Signs of magnesium toxicity include loss of deep tendon reflex, somnolence, and respiratory depression. Because magnesium is primarily excreted by the kidney, a common risk factor for toxicity is renal insufficiency, elevated serum creatinine. They have been given the creatinine level. Okay, okay, I missed that one. So I'm on a correlate. Okay, because magnesium is excreted by the kidney, a common risk factor for toxicity is renal insufficiency, that is elevated creatinine. As in this patient, patients with known renal insufficiency or suspected toxicity require monitoring of serum magnesium level and adjustment of the magnesium rate, like lowered rate. And calcium gluconate is the first line treatment for toxicity. Okay, it is, yes, yes, yes.